very much. Cheers. Perfect. Thank you. Cheers.
All right, welcome back, everyone, on this rainy afternoon. Thank you for still being here, and I hope we had some fun talking to each other. And the final session now will be given by Sir John Aston. I apologize. And he will talk about data in healthcare. So I'm very looking forward to that.
Brilliant. Well, thank you very much, and thank you for having me. And even though it's only a very short walk from my office, I did worry about coming across in the rain as it was earlier, but luckily it seems to have held off. So today I'm going to talk about where massive information comes in when you're looking at data for healthcare. I'm very grateful to the support from the David and Claudia Harding Foundation for the work that's for supporting an awful lot of this work. This is very much joint work, particularly with Ayadi Lilla, who was a PhD student here in CCIMI, but is now an assistant professor at University of Washington. And then with Carola and James, who lead with me the Center for Massive Information in Healthcare, and then Alex Freeman and David Spiegelhalter from the Winton Center. So I'm going to start by saying, in actual fact, data and healthcare and maths use of maths within that is not something new. Indeed, if we think about the Radon transform, which was, celebrated its 100th anniversary not that long ago, this is now integral to pretty much every piece of medical imaging that happens around the world. So the fact that, a piece of maths allowed medical imaging to occur really sort of says that there is some kind of integral and close relationship that allows the use of data and the use of mathematical models to actually help inform healthcare. But this is a bit of a cheating example because in some sense the maths came first. Radon didn't design it for medical imaging. He designed the transform, and then people worked out that you could use the transform to do medical imaging. But if we go back even further in history, this is the polar mortality diagram that Florence Nightingale had in the Crimean War. And this is a piece of data analysis that was really for healthcare. She looked at, here is this is from 54 to 55, and this is from 55 to 56, 18, 54, 55. She looked at the causes of death across the year. So this is a sort of circular diagram as the year goes round. You can see the months of the year. Red was from battlefield injuries, black was from other, and this bluey color is from communicable diseases. And by using some mathematics and using some ideas of understanding how you could, very simply, but use maths to display this information, she not only showed that the interventions she put in reduced the area of this diagram to this diagram, so she was saving lives, but that also, somewhat to the surprise of the military, battlefield deaths really didn't account for very many of the deaths to their soldiers. It was much more about communicable diseases. So if they could solve people getting communicable diseases, they'd reduce their numbers of deaths massively. And this is an example of data analysis in a healthcare setting 150 years ago. So I think that, and I'm obviously going to say this, I think that maths is integral and a really important part of actually doing healthcare analysis, and I think we're seeing that more and more with the healthcare data analysis. So in this talk, I'm going to talk about three things. First of all going to give you a quick overview of the Center for Massive Information in Healthcare, which is a sort of sister institute to CCIMI, and some of the things we've been doing there. I'll then talk about an explicit area where we look at a project looking at medical image analysis of surface MRI. And then in the end, I'll talk a little bit about how the fact that we can't just use our maths and produce some really nice output, we actually do have to explain it, particularly to those who are going to use this. And I think that's really important in this massive information era, that it's about allowing the people who have that information to really understand it. And so we'll talk a little bit about how you might do statistics and communication. So what is the Center for Massive Information? Well, it's this sort of hub that we have It's funded by EPSRC, so we've had the first iteration, and the second iteration started in 2020. It's got about 19 co-investigators across the university, and I think that's an important thing. It's not just mathematicians. It really is bringing mathematicians, engineers, and clinicians all together to try and use that analysis to really help build the ideas of data. And we're looking at 4 specific diseases. We started out with 3, cancer, cardiovascular disease, and dementia, but then, of course, added COVID, because it happened during COVID, and therefore, wanted to look to see what we might be able to do, how we might be able to use some of the analytical tools we have to help with COVID. It's truly interdisciplinary, and the idea is to develop algorithms, but then develop algorithms that are robust enough that they can actually be used in clinical settings. I don't know about any of you, but when I go to hospital, I don't want the doctor to go, well, this is a bit of a experimental software that might have bugs in it. I'm going to plug your information in, this is what I'm going to do on data. No, I'd quite like it to be robust. I'd quite like it to actually work properly if it's going to be used to make my healthcare decisions about me. So, lots of research objectives, and I'm not going to put these slides up for very long, in the sense that if people want to see these slides, the research objectives and the next mathematical challenges are in the slides. I'm very happy to share the slides. But the idea is that in order to do this, we actually have to develop new mathematical techniques. It's not just good enough to say, we're going to use what's out there already. Many of these problems require new maths in order to do that, which is why we're interested in doing it. But the idea is to then actually improve patient stratification. We're going to use both imaging data and non-imaging data. Look at this, look at this lack of robustness that we were worried about, and work out how we can deal with that mathematically. Develop new tools, platforms that allow you to use this, and then actually use that in the real challenges surrounding cancer, dementia, cardiovascular disease. So how do we do that? Well, we do that through some new maths. And so the idea is that we try and work out how to do integrative data analysis from lots of different data sets. How do you bring data from the clinic with data from images, from data from genetics, all of that together to actually allow you to make robust diagnoses that you can actually use in the clinic? How can you do that without someone having to tune it all the time? How can you do that in a minimal supervision way? Understanding this has got to be done with both statistics, computational complexity involved, because you don't want to do this fast, you need to do it robustly, you need to optimize these things in a way that actually does this in a sort of completely justifiable way, because that's how it's going to be able to be used in the clinic, and using the best of both worlds. So we know that lots and lots of really good maths has physics-based models underneath. Really sort of physics understanding models, but there's an awful lot that's coming out of AI as well. So how can we combine the two to get the best of what we get? So I'm going to give you 3 very quick examples before I sort of spend a little bit more time on a further example. So the first example I'm going to talk about is artificial intelligence for Alzheimer's disease. This is some work that's been primarily done by Angelica Aviles Rivero, who some of you will know. She's done lots and lots of work about how you can use graph neural net models with huge numbers of collaborators to really understand how you integrate imaging data and non-imaging data to look at the diagnosis or prognosis of Alzheimer's. And it's this bringing together these different types of data that actually allow you to understand what's going on. And it allows you to have this sort of idea of how can you predict what's going to happen, how can you predict what is going to happen to people with Alzheimer's. And I'll show you another way that you can use these kind of ideas to how you might predict using simple, in these cases relatively complex, machine learning methods to get some idea about the actual healthcare structures that you're interested in this case dementia. The second project I want to very quickly talk about is on COVID. Now, COVID took over the healthcare system, but it also took over most researchers. They actually started to think about how can I actually make a difference? There's a massive pandemic happening. How, as a researcher, can you actually do something to help? And in this case, we came up with many, many projects led by huge numbers of people. Particularly want to mention Mike Roberts, who's done a huge amount of work trying to make sure this all comes together. And the idea was, can we understand, using all these different types of data, how we might find better, more understanding around COVID? And indeed, for a lot of the mathematical models that were proposed, lots of people proposed machine learning kind of models for COVID, how robust are they? Should they be used in the clinic? And so Mike did some really nice systematic reviews to say, in actual fact, a lot of these things really aren't reproducible. And I quite like to have reproducible data and reproducible analysis if it's being used in healthcare. So really understanding that, but then also understanding how you do things like imputation, where you don't have all the data that you might need, how you might take chest x-rays to understand how you might further prognosis, take all this data from tomography data, chest x-ray data, clinical data, and combine it all together to really understand what's going on. A really nice offshoot of this is some blood imaging work, the Blood Counts project, which some of you will have heard of, and really trying to understand how that can be used as a sort of surveillance diagnosis system. Really looking at how we can use sort of anomaly detections ideas from machine learning and statistics to really understand how you might look for the next pandemic, or at least hopefully see it before it becomes too much of a problem. But really understanding that in all of this, garbage in is garbage out. So really understanding how to put quality in this. My final quick example is the fact that this doesn't just have to be about the latest disease or big disease. In actual fact, the healthcare system is a really right area for understanding and using mathematical machine learning operations research kind of techniques. And while it may not be the most exciting to look at, most exciting thing that's being reported in the news, it could potentially have the greatest impact. We know that, particularly from COVID, there's been huge changes in the waiting lists for almost every disease. How can we use these kind of techniques to actually optimize waiting lists, etc.? So this is an example looking at cardiovascular and severe aortic stenosis. There are very, very large waiting lists associated with this. By looking at some sort of relatively simple but powerful models, it was shown that you can actually sort of make some choices about whether you use one treatment technique over another. These are Sava and Tavi are two different treatment techniques. And you can decide how much you want to increase capacity or change the treatment technique and what's going to be the cost of that. And it's sort of, you have a number of deaths who are going to happen because they're on the waiting list. Can you trade that up or down by changing the number of the number of cases you look at with one particular technique or at another, in order to understand how that would compare with the much, much larger numbers of deaths that would come simply by letting the waiting list run at its normal rate, given what we currently do. And so this doesn't work just for cardiovascular disease, but in actual fact is applicable to almost every kind of waiting list going, depending on what you want to be used as your indicator for the cost. In some cases, in this case, it will be deaths. In others, it will be quality of life lost. So you can build models for all of these things in exactly the same way as you can build models for many of the individual diseases that we've talked about. But what I want to talk about is specific areas where you can actually really get into the maths as well. So I'm going to talk about brain imaging. This is a left hemisphere. And what you can see is that that part there is the part that joins the two hemispheres together. So it's not on the surface. But the rest of this is on the surface. Now this represents a particular function that sits on the surface. So that could be it could be the thickness of the cortical surface. It could be the amount of activity of the cortical surface. The cortical surface is actually the area that most of your brain activity is happening on. The white matter underneath is where the connections between the grey matter areas are, but the grey matter is actually where most of the activity in your brain is happening. So while you're listening to me talk, the auditory cortex part of your brain is activated in order to work out what I'm saying. So what we want to do is understand how we might do the analysis, taking into account that the brain is a 3D object, but the cortical surface can be pretty much well represented as a two-dimensional surface of this 3D object. So there are some spatial constraints. So if I think about it, that point there and that point there are relatively close in Euclidean distance, but I've got to go down and up the sulcus in order to get to them. So it isn't simply saying, well, this is just a 3D Euclidean geometry. I've got to worry about the surface that I'm sitting on in order to do the analysis. So what kind of data are we going to look at? We're going to look at all sorts of different data. So to start with, we're just going to look about how different parts of the brain are connected together. And I'll come on to why that matters in healthcare in a little while. So this is looking at some data from the Human Connectome project. It's about 500 subjects worth of data where you've got their extracted surfaces. There's some pre-processing to make sure that they're all aligned up. And this is resting state fMRI data, which is effectively someone's put into an fMRI scanner. They lie there for a little while with their eyes open or closed, depending on the protocol, and you just record what their brain's doing. And it's well known that when you're resting, certain networks, certain brain networks, often called the default network, are active. And they actually are pretty active in that time. So what we understand is what are the different connections in the brain, noting that most of that activation is happening on the surface. So functional connectivity is about these connections, and it's well known that this precuneus area, which is this area in red, is active during the default network. It's active during rest. So one question we could ask is, how is the rest of the brain surface connected to this precuneus area? Now, what do I mean by connected? Well, you've got to give a definition. So I'm going to give a mathematical definition. I'm going to say, look at my time series I had here. For each spatial location and within each subject, I can say at this spatial location, how is this time series correlated to this time series here? So I get a time series at every spatial location on my surface, and I'm going to use that sort of correlation as my measurement. So what these maps are is that these maps are of correlation between different areas, correlated to the average of this red area. So what you can see is, well, not surprisingly, this red area is quite correlated to itself. I've taken the average, not surprisingly, so that's why it's dark here. But you see that, around it, there's other areas that are relatively dark, but there's also other areas, front here, that are also relatively dark. So there's connections across that as well. And I want to understand how are those connections done. Now, one of the sort of things that's interesting about some of this is that we can start to ask mathematical questions too. So, I've given you a particular region in this. I've taken it from the anatomical literature, the precuneus. But are there other ways that we can mathematically think about how we might define regions? Are there things we can do that actually allow us to do this automatically or from a principled mathematical point of view? I'm going to treat it as something called functional data, which is effectively the analysis of curves and surfaces. So I'm going to triangulate my surface in order to be able to do it discretized on a computer. But you could think of this as a continuous surface object that I want to try and do the analysis for, and I'll show you the analysis in just a second. It's a sort of two-dimensional manifold sitting in 3D, and the discretization is sort of about 32,000 nodes of this triangulation. So I've got lots of subjects. I've got a map from my manifold to my values of my, in this case, correlation. How correlated at each point is it to my precuneus? And it's observed on these, we're going to assume it's observed on these nodes. So, as a very quick aside, we can also use mathematical ideas just to simply think about how the brain might be working. So this is a quote from Jonathan Swift, and he said, if you look at a flea, well, that's sitting on something, and that flea might have a flea on top of it, and that flea might have another flea on top of it, ad infinitum. You can think about the brain in a sort of similar way. Well, what do I mean by that? What I mean is that if I take a regression at a particular point in my brain, correlation kind of idea, then maybe if I think about the area that that's contained in, if that's kind of if that correlation is meaningful, then maybe the correlation of the bigger area is meaningful. That's why I took the precuneus. I took that area because I think that whole area is kind of known to anatomically be quite interesting. But if I now take points within that precuneus, they're also interesting because the whole precuneus is interesting. And I can simply keep building this up. So for those of you who know about wavelets, they have sort of, they have this idea of time and frequency localization. Well, the idea is that if I look at different frequencies, if a particular large frequency is interesting, then likely the smaller frequencies under that are going to be interesting. Yet, if in the localization the big thing is not interesting, probably unlikely that anything underneath it is interesting as well. So we can actually start to think about how do you design models that take into account the sort of intuition, but understanding that we know about these kind of things from mathematical constructs. Does it work? Well, in actual fact, in this case, this is looking at a map of something called FDG, which looks at the glucose levels, so the sort of activation levels in your brain from blood glucose. So looks at a sort of measure of the brain at work. We see that if you just do it in a raw way, you get quite a noisy map. But if you take this Bayesian regression into account where you say, well, if something's happening at a particular area, it's likely to be, the small areas might be interesting. But if it's not happening in that big area, the small areas aren't likely to be interesting as well. You get a much cleaner signal. Now, for that, I simply took some wavelet basis. But, I can ask the questions, what function class should I take? What mathematical function class is a good class to think about for brains? It's a perfectly reasonable question. And also, if I'm going to presume that there is some tree-like relationship between these things, what kind of mathematical function class will actually allow me to have good tree-like relations for these so that I can use my Bayesian system where I can say, if this prior level is interesting, then probably the ones underneath are as well. But going back to my surface data, I'm going to think about my surface data in exactly the same way as you might normally think about statistical models, which is to try to find a basis expansion of my data. And I'm going to use the sort of best basis expansion, which for those of you who know about principal component analysis, is exactly principal component analysis. All it's saying is, if I have some data and I want to find the best linear basis approximation, I first of all remove my mean, and then I find the set of principal components, or eigenvectors, or eigenfunctions in this case, because I'm going to assume this is a surface function. I'm going to look to see how I can minimize the difference from my data, which is exactly principal component analysis. Now, this is principal component analysis in the function space, so I need to do that appropriately over my manifold. But for those of you who want to think about it as standard principal components on a sort of multivariate vector space, it's exactly the same effectively. But this representation couldn't care less about the fact that I was sitting in some kind of surface-based approximation. If you think about principal components on a multivariate vector, I can scramble the entries of the vector around, and I still get the same principal components out. That doesn't sound right if I'm talking about surfaces. I showed you that some points are close to each other in the surface, other points are far away. I need somehow to say that they're not all the same. If 2 points are close together, they should be sort of seen as close together in the analysis. How am I going to do that? Well, I'm going to do that by putting some penalty on my principal components. If I deviate too far from the smoothness of my data, then maybe somehow I can use that and say, well, that's not probably a very good principal component. So what am I going to do that with? Well, I'm going to use some geometric concepts. I'm going to basically say, well, if I look at a part of my brain, I'm going to look at a tangent space approximation, and I'm going to define some basis on that tangent space approximation. And if I can look at some kind of local structure, and that local structure can be incorporated into my principal components. So by looking at that, I can define this new basis that allows me to actually work out how to do this eigenexpansion, taking into account the local structure, the local smoothness of this surface at different places. So what do I get? Well, this is standard principal components. This is saying I want to minimize at each of my spatial locations the principal component decomposition over some set of principal components. But I'm also going to penalize that set of principal components. And this is the Laplace-Beltrami operator, which is effectively an operator that's going to penalize things that are far away when that they go away from the surface. And so by adding this extra penalty term, I'm going to constrain my functions to live on my surface. So this is my data-driven term, and this is my sort of physical model-based term. I know that there is a physical model of the surface involved, and I'm going to use this Laplace-Beltrami operator to fix that physical model into the system. And so I get this overallized minimalization technique, and by choosing lambda through cross-validation or something else that makes sense, I can regulate the levels of data to my physical model of being the surface. So what does it mean? Well, I'll show you. So this is the output from that analysis. This is the output from my cortical surface analysis of connectivity. So MVPCA is simply multivariate PCA. This is saying I don't care about the surface structure. I can just take a multivariate vector, and I'm going to treat it as if it was just a multivariate vector of data. Who cares about the surface? Heat kernel smoothing, PCA, is I'll do the same principal components analysis as I did in the multivariate way, but I'm going to first of all smooth my data across my surface. I'm going to use a heat kernel kind of approach to smoothing, and I'm going to enforce the smoothness on my surface data through smoothing it first. So smooth first, then do PCA approach. So that's equivalent to saying I'm going to apply some kind of smoothing operator on my surface to my data before I start, and then I'll just solve principal component analysis in exactly the same way. This one is solving that optimization function there using k-fold cross-validation to actually sort of regulate the amount of smoothing and the amount of PCA that you do at the same time between. So first principal component doesn't look that different really. It's pretty much the same. So at a grand scale, the data is telling you what the data says. It doesn't matter whether you take the smoothness into account or not. Second principal component, we'll start to get some differences here. So this is multivariate principal component analysis, and this looks much rougher than these two principal components. Well, it's not surprising. Multivariate principal components has no smoothness constraints in it at all. I can shuffle the data around in any way, shape, or form I like. Why should there be smoothness? Well, there shouldn't. So, it's still similar, but it's certainly much rougher. So somehow they're saying there is an intrinsic smoothness to the data. If you smooth it first, you get sort of a similar principal component. That doesn't happen if you just do multivariate principal components. But then look at the third one. Here, multivariate principal components are, they're somewhat smooth, but they're also somewhat rough. This principal component is very smooth, and this one is somewhere sort of closer to the multivariate principal component. So somehow this is now less smooth than smoothing the data first, which is kind of nice, because what that's saying is if something is non-smooth in every single one of my patients, I want to keep it. But if I smooth the data first before I do every single patient, I take the patient's data, I smooth it away in every single patient. So when I then put it together, I can't see it anymore because it's been smoothed away. Whereas here, I can have the smoothness when I want it, but when I see that something's occurring, there's something in those principal components that actually seems to not be as smooth as my data would be if I smooth the data, I get it out as well. So you can get that trade-off, and that's exactly the trade-off you see here. You get some smoothness, and you get some part from the data, and I can actually have both of them in my principal components. So that's all great, but what do I do if I want to actually think about, so that was all sitting on a surface and looking at the data on a surface. What if I realize that my brain and everybody else's brain in here is different? I need to look at how can I compare what's the mean of my brain to the mean of your brain? What does it even mean? What does it even mean? It's how can I say what's the spatial relationships and how is that important? Is it important if I'm going to get Alzheimer's disease that my brain is one shape versus your brain is a different shape and you're not going to get Alzheimer's disease because of that shape? How do I take that into account? So here I need to set up a model that looks at a template brain, and I shift that template brain to yours and my brain, and this is some kind of deformation field that moves my brain to your brain or the template brain to your brain. This is the kind of signal that sits on top, and then if I want to see the data that I actually see, well, I take that signal and I apply the same deformation field to that signal to get back to the template that sits on top of my data. So that takes my data from this signal, which sits in my template, and I move it to the signal that sits in my brain. What does that allow me to do? Well, it allows me to then think about how geometry and function go together. So previously, all the principal components you saw were principal components around the function, the connectivity on that particular image, that particular template brain. But I also now want to understand what's the trade-offs between different parts of different shapes of brain affecting those functions. So what I want to know is, do those functions that we've seen before depend on whether you started off with a brain shape that was relatively smooth or a brain shape that had more sulcuses in? My brain shape may have more sulcuses in one area, more sulci in one area, less sulci in another. Your brain shape may have more sulci in that second area and less in the first. Does that affect the kind of signals I see on the brain itself? So I somehow need to combine all this information together, and I can do that by looking at the two different components. I can look at it looking at the deformation fields and the signals on top of my brains themselves. So I can do that. I can take a particular subject. I can look, and you see here, different brain shapes. I can map them to each other. Once I get into a common template, I can then extract them and get a connectivity map. This tells me about how different regions are connected to each other. These are correlation or covariance matrices. That makes it even more difficult because these are now positive definite matrices that sit in some space as well, but let's not worry about that too much. You can do the analysis in exactly the same way. And somehow I need to understand, well, I've got this deformation. How am I going to take account of the deformation in these shapes as well? Well, I'm going to do it by having a joint model. I'm going to have a model that looks exactly in the same way as, remember, we had our local geometry for our on our surface before. We're now going to look at the local geometry of individual brains. So this might be my template brain, much smoother. And this might be how I move from this template brain to my brain, to your brain, to somebody else's brain. Understanding how I move around that geometric space allows me to get some idea of what principal components are in that geometric space. I can do the same for my positive definite matrices or my covariant, or my connectivity matrices, and I can now move around these and understand how I can put together all this information to allow me to understand the relationship between the shape of your brain and the connectivity of your brain. Now, we can use all the same methods that we've done before, exactly what we did for the single brain shape. All of that can be done before, but somehow one of the interesting mathematical questions is, can I use the different geometries in a different way? Can I use both the brain geometry, how the brain itself is structured, but also the geometry of these function spaces? So this is a positive semi-definite space that's got a particular structure to it. What kind of analysis can I do there? These are a space of manifolds sitting, two-dimensional manifolds sitting in 3D. How can I move around that space in an efficient way? And can I use those kind of ideas to extract the information most successfully? Now, that's all been very theoretical, very nice. Why do I care? Well, I care because I can use these geometries to actually make classifications. So I can put these geometries into a classifier. This is some very recent work that ARD's done. And you can show that. You can design a classifier that looks at differences between control patients and Alzheimer's disease patients, simply by taking these geometries into account in an appropriate way, understanding the function spaces. So with all that work, you can actually produce something that has a clinical usage, a clinical way of determining whether someone's likely to have Alzheimer's or likely to be a control patient, simply by the geometry of their brain and the underlying functions on it. So that's all great. That's really sort of, some really nice maths that really does actually help something. But if I show that picture, or, maybe let's say those sets of equations to the average clinician, they're probably not going to buy into my method. They're probably going to go, well, what are you talking about? So part of what we have to do is actually communicate this to people as well. So the last part of the talk, I'm going to talk about how you might actually communicate some of the analysis you do. And I'm going to take a very simple analysis that we did and show how it can be communicated out. So this analysis comes from vaccination data. So this is COVID vaccine. This is the COVID dashboard in sort of April, coming from January to April in 2021. So this was when the vaccine was first starting to be rolled out, predominantly at that point to older people, although healthcare workers were being it was being rolled out to healthcare workers as well, and that's very important for the analysis we'll show in a second. This is the hesitancy rates amongst different age groups. Now, it's still very high. I think that's about 80%. I think I can't see it quite so clearly here, but I think that's about 80%. But you'll see that those who are 70 years or older have almost 100% wanting to uptake the vaccine. But when you got down to sort of 16 to 29-year-olds, it was bouncing around about, between 80 and 90%. Vaccination works if you can get most of the population vaccinated. So there were some questions about, what was going to happen with vaccination as it got rolled out to younger people. It was also not equally, there was difference in vaccine hesitancy amongst adults depending on the levels of deprivation. If you lived in the most deprived areas, you were more likely to be vaccine hesitant than if you lived in the least deprived areas. So we know that COVID doesn't, is more likely to have, more likely to get seriously ill if you lived in most deprived areas, yet that was the areas where there were most difficulty in potentially vaccine uptake. So, as many of you will remember, in April 2021, there was a scare around the vaccine. So what happened was the AstraZeneca vaccine, which was being rolled out across the country, suddenly there seemed to be a set of reports of serious side effects of having the vaccine. This was blood clots, and people were worried that in actual fact that by taking the vaccine they were likely to get a blood clot, and these blood clots were, serious enough to land you in intensive care, and for very sadly for some individuals they died from the blood clots. So the sort of equivalent of the Food and Drug Administration in the UK, the MHRA, wanted to know, was the vaccine safe? And it was important because what they wanted to know was that if the vaccination program was, as we've all now, very luckily, we're all sitting in here because we've had a successful vaccination program. The problem was, though, that if the vaccine was not seen to be safe, then maybe the vaccination program wouldn't have the same effect. People would stop being vaccinated. So they wanted to know what the effects were. What's the harm? What's the likelihood of having a serious blood clot? The problem was the vaccine wasn't being given randomly across the population. It was mainly being given to older people, but there were also people who were younger getting it because they were healthcare workers, predominantly, or had other serious conditions. But it was mainly healthcare workers in the younger agents who were getting it. Unfortunately, the risk of the side effects seemed to be happening more in young people than in old people. So the group that would be most benefit from having the vaccine was gaining from it. The people who were least gaining from having the vaccine were having the blood clots. So it's not a particularly easy message to get across. So you can use a relatively simple statistical model to look at this effect. It's a Poisson regression model. To see whether there was an effect, whether this was happening, and was there a link to age. But if you're talking about harms and benefits of vaccination, you need to know what the benefits of vaccination too. But if you get vaccinated from getting COVID, particularly in this room, most people in this room, if you get COVID, you may not feel very well, but you're probably not going to die. So what is a fair set of benefits to look at if you you could potentially get a serious side effect that could ending up very ill. So serious side effect, well, entering intensive care seems to be a pretty serious side effect. So therefore, let's do the same. Let's say in COVID's case, what benefit do you gain? Well, let's say you don't enter ICU from COVID. So how do you enter ICU from COVID? Well, you first of all have to catch COVID from the population. Secondly, you have to become hospitalized with COVID. And then thirdly, once you're in hospital, you have to enter ICU. So in order to work out what's a fair harm-benefit trade-off, you need to look at those things. And then you need to understand the efficacy of the vaccine. How much does the vaccine stop you entering ICU from COVID so that you can then make that trade-off? And luckily, they were starting to collect those statistics by age, which was the thing you need to be able to compare against people who are likely to get the benefit of the vaccine or the harm from the vaccine if it was an age-related problem. So the big thing is that once you've got this information, you've got to communicate it. And luckily, there are some really good people at communication. For those of you who have been in the UK a while, most of you will know Jonathan Van Tam, who was the Deputy Chief Medical Officer for the UK, and he, along with his colleagues, so June Rain from the MHRA, the Medical Health Regulation Agency, William, who was from the Joint Committee on Vaccination, and Professor Mahmoodi, who is from, Professor Prem Mohammed, who is from the Medicines Commission. They had this joint press conference to talk about what the harms and benefits would be about the vaccination program and how could you then use this. And what did they do was they used this data, and we were very lucky. They asked us to fit the model and to produce some images that would hopefully help people to understand what was going on. Now, the images they asked us to produce were for the decision-making people. It was for the Joint Committee on Vaccinations and Immunisations. They asked us just to produce some things so that they could quickly look to see what the harms and benefits were. They then we were very lucky. They took those and actually ran with them on their BBC News broadcast about how to explain the differences. And this is what it said. Well, so look, for a low exposure risk, and this was based on about incidence of 2 per 100,000 people, for 2 per 10,000 people, which was roughly the level in March 2021. That was a low exposure risk. It's quite hard to get COVID if you've got that kind of exposure. Not impossible, obviously, but not. If you were 60 to 69-year-old, the chance in 100,000 people, 0.2, so 2 in a million people, would end up with a blood clot that would end in ICU from the vaccine. But about 141 people in a million, or 14.1 in 100,000, would end up in intensive care from COVID. Clear benefit to having the vaccine. But the problem is the risk of the blood clots in the vaccines did go up as you got younger. So by the time you're 20 to 29 years, we know people who are 20 to 29 don't end up in ICU with COVID. So there is now sort of, and noting that these numbers are not, perfect, it's not that different between the two. And if anything, it's a little bit on the other side of having the vaccine. Now, this is not taking into account things like transmission risk. If you want to go and see your grandmother, you probably don't want to have COVID, because that puts them back up here. But as a 20 to 29-year-old, it's sort of a balanced process. But that's if it's low levels of COVID. Remember I said that the only way you can think about this is, well, what's the chance of catching COVID? Well, if the levels of COVID go up, so this was what it was in February 2021, now it's looking a bit more balanced. If you're 60 to 69, there's a huge advantage of taking. It doesn't change your risk from having the vaccination. The vaccination is a one-off injection. It's not going to change depending on what's happening with COVID in the environment. And if it gets to high exposure risk, which was the peak of the second wave in January 2021, it's now clear benefit for all ages of having the vaccination. So that was all fine, but this was in sort of April 2021 when levels were more like that than that. So what the JCVI recommended was, and we were very lucky, there was another vaccine, there was Pfizer. It uses a completely different biological mechanism and therefore which didn't have the blood clot risk. They recommended that, first of all, 20 to 29-year-olds and then later 20 to 40-year-olds receive the Pfizer vaccine, not the AstraZeneca vaccine. But for everybody else, the fact that AstraZeneca could be rolled out much more easily and quickly, it was still very worthwhile having AstraZeneca as the vaccine. And people accepted it. People saw the data. They wouldn't necessarily understand the models that were behind the data, but could clearly see the harm-benefits trade-off, and there was no change in vaccine uptake. You could imagine that you could have got headlines of killer jab kills people through blood clots, and then a whole bunch of people wouldn't have decided to take the vaccine. But because you explain the maths relatively clearly, I hope, you get a different view of that. And unfortunately, in other countries, they didn't do it that way, and there was a vaccine uptake decrease. So what did we get? Well, we got the Sun headline that looked like this. So it did say killer clot, but tiny chance. And I mean, I don't know how many of you read the Sun on a regular basis, but for those of you who do read the Sun on a regular basis, you will know that they do not put numbers on their front page. The Sun doesn't like numbers, but they put our numbers on the front page. And they did that because they got the fact that it was a tiny, tiny risk, and they needed to capture that. So because Jonathan Van Tam did such a good job of explaining it carefully and slowly, he took his time, he used ways that I hope were fairly intuitive to everybody, people like the Sun didn't run the story of, this is awful, no idea what's going on. They just went, well, yeah, this is sensible. They made a change, they decided what's going on, and they've moved it across. So I think that's sort of pretty good and very few alarmist headlines. So in summary, I think that massive information is integral to healthcare data, but only in certain circumstances, and that is we must consider real problems. You can take mathematical approximations, but then you must in the end work out how you can apply it to those real problems. you must consider the fact that you have to do some novel maths sometimes. Sometimes you can't just assume that the maths you know is good enough. Sometimes the assumptions that you need for the healthcare data really does not fit the assumptions that you already know and you've already built the models for, so you're going to have to change the assumptions. And that can sometimes make the maths hard, but it also makes the maths fun. And then I think after all of that, you've got to realize how you can then communicate those results to the public, to healthcare professionals, in a way that allows them to understand it rather than just you. With that, thank you very much.
Thank you, John, for this very nice and informative and excellent talk. Very, very important. Are there any questions?
For fun. Yeah, I can hear you fine.
All right, great. Thanks a lot for the talk. My question is surrounding the first section of the talk. Start obviously off with issues of the COVID counter and relevant epidemiology for data are possible, and then it falls into this bigger area of social statistics and such, right? And how to inform decision makers and the public. The question I have is usually that in the bigger data situation, right, high dimensional data, often let's extract a very small subsection of the data we have and then make interpretations and suggestions that we have. So then this extraction process can be quite subjective, right, depending on what kind of information we pass to the decision maker or public. So in this sense, okay, good. So in this sense, what would be a sort of more objective way to do it, such that we can be more fair to the data itself in the context of high-dimensional data?
So I mean, it's a really good question. I suspect that there are ways that you can try to design your analyses so that it is as least subjective as possible. But you're always going to make assumptions. That's fine. What you don't want is to people believing that you haven't made assumptions. So I think it's really important that when you talk to people, they understand the implications of the assumptions for them. It's no good saying, well, I used a second-order lasso penalty. That doesn't mean anything. But if you do say, well, in actual fact, I used something that means that I'm only ever going to get a few variables out, and therefore the fact that I started with 100 variables and I only got these 3 out doesn't mean that all those 97s are completely irrelevant. That helps someone to understand it. So I think, for me, you're always going to have assumptions. You just somehow need to work out how you can take those assumptions and explain them in a way that people then know that the decisions they made are being based on a set of assumptions.
But what if the assumptions are not postulated? I mean, in the case of vaccination, there will always be voices against it, those anti-vaxxers, right? And then the question is assumptions, and then they say, well, I don't believe in these statistics because they don't like the assumptions. So how should we do that kind of thing?
So that's a good question, and I think the argument is that you can often work out what they're going to say. And I think what you say, to start with, is you will find that people will say this about my assumptions. They are wrong because of this. And so when they then go, this about my assumptions, you go, yeah, but I heard that already, and they told me you'd say that. And that's a completely different response than, ooh, not quite sure why they're saying, have they got a point, have they not? If you've addressed that, so I think a lot of this is about proactively thinking what kind of criticisms and challenges can you have and being honest about them. And, I think I would find it much harder if the government had stood up and said, you know what, we've made a decision and the vaccines are safe for you, go get on with it. I'd worry about that. But the fact they said, look, no, there is a harm. We're not going to lie about it. There is a harm, but, it's up to you. You can make a judgment. But look, if you're 60 to 69, you probably don't want to not have the vaccine. That makes it, that people were aware there is a small chance of getting a blood clot, but there's a much higher chance of getting COVID and being seriously ill with it. And I think that helps. People are a lot more rational than we sometimes give them credit for.
More questions? Maybe related to the first part of your talk. So certainly the Radon transform was very important and influential. And now looking at the role of mathematics as it is now, and somewhat, yeah, I mean, you looked at a specific problem with your fMRI data. So there's certainly a lot of research being done now to use math to describe interesting problems in healthcare, but how far is it, or how difficult is it to actually see them applied in practice? Because I know a couple of doctors, and I know what systems they use, or like mostly paper-based and very simple tools to do their work in everyday life. So how difficult is it actually to implement these new insights in reality?
So yeah, I mean, it's not easy. I think that's I mean, I think anyone who says it is potentially pulling your leg a little. I think I think we have to be quite careful in the sense of, there are some things that doctors have been doing very well for a long time, and we shouldn't think that just because we can design an AI algorithm that improves the the prediction rate from 96.1% to 96.2%, that suddenly they should all be using our algorithm. I think I'd probably still go with the old algorithm at that rate. But I think trying to make sure that we help people come along by making sure that we communicate it well, helping them understand what they can gain from doing this. I think absolutely agree that there's a lot of doctors who are slightly nervous about these new systems and not have old ways of doing things. The data's not that great, etc. Surprising number of doctors who actually want to learn a bit of maths now, which is really good, in the sense that they want to meet us halfway. Most doctors I know are not going to come and do a PhD in CCR. Yeah. However, they might be prepared to learn just a little bit, so that when you talk to them, they have some idea about what's being implemented, and I think that's a really encouraging thing. So, James Rudd, who's the one of the co-authors of the talk, he's a cardiologist, but he's learned more and more kind of about statistics and machine learning algorithms, because he sees that there's a massive value to what he wants to do in the clinic.
Yeah, and there's certainly a need for that. I can confirm that. Any other questions to John? Okay, so it's certainly getting late. So let's thank John again for this excellent talk. And many thanks for coming along in the late afternoon. Yeah, and then let me give a few closing remarks as I announced in the program. So many thanks to everyone who joined today, and I hope both people from academia and from outside academia enjoyed the event a little bit, networking with each other and with new people. And so now I certainly want to thank again all the CMI PhD students who gave elevator pitches and poster presentations, and thank them and congratulate them for using this excellent opportunity to talk to each other, because this is one of the central points of the program, and I'm happy that so many came to do an elevator pitch in the end. Okay, and then the final point is to give a poster prize. We had 3 posters, but only 2 posters from early career researchers. So I hope this more motivates everyone else to also participate next time, because I think posters can be fun. They can take quite a bit of work to create, but I highly recommend going through this process, because at some point, maybe at conferences, you have to do that anyway. And if you have a nice poster layout, then you can always manipulate it afterwards and reuse it. So and posters can be an excellent form of communicating research. So it's something worth practicing. And so in the end, we looked at the posters, and we decided to give the poster prize, which is a book voucher as far as I know, to give it to Oscar this time, and for like a very nice presentation. And I mean, not that the presentation was the deciding point, but just for an excellent presentation of the content on the poster, and and to reward the enthusiasm for that. So, well done, Oscar. So I don't know how this works now, but in any case, so that's it for today. And I think the next event will be the academic conference in half a year. And for the CMI students, next week we have another industry event actually on Wednesday. So Emma Slade from GSK will come and give a talk. So I hope that many of you will show up for that, because I think it will be quite fun with her. Okay, then yeah, many thanks again for coming, and yeah, see you soon. Have a good day. Oh, there are drinks, yeah, come out.